This episode is sponsored by Romanwell. IBD is every day. So shouldn't you have access to the nutrition support you need every day too? The folks over at Romanwell couldn't agree more. Their team of IBD dietitians works with you to develop a care plan that is uniquely tailored to your specific lifestyle and provides the daily support you need in order to expand your diet, reduce your symptoms, and gain a better relationship with food. Head over to romanwell.com to apply for a complimentary consultation and tell them Robin and Alicia sent you.
Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Smita Mehta. Smita is a pelvic floor physical therapist and part of a multidisciplinary team dealing with IBD at the Brooke Army Medical Center in San Antonio, Texas. We talked to her about what exactly is pelvic floor physical therapy and how it can help people living with IBD. This episode truly was a revelation. I hope you enjoy. Cheers.
Hello, everybody. Welcome to the show. This is Robin.
And this is Alicia. And we are really, really excited for our guest today. I think we say that about everybody because we love talking to everybody, but this one is...
We just love talking. We love talking.
We do. Yes. We love this. But this one is particularly good for us. And so today we are joined by pelvic floor therapist Smita Mehta. Smita, we are so excited to have you on because we were just talking and I said, I've talked to 4 people in the last, probably at least one a week for the last month that has brought up pelvic floor therapy. And so this feels super timely and feels very, very necessary for our community to know more about. But we're going to start out by asking you, what are you drinking?
Okay, so this is what we drink in India for summer, and it's called, I don't know if you guys are green mango. So this is green mango virgin mojito with some mint. It's a pure summer drink.
Oh,
love it.
Sounds so good.
It really does.
I've never had a green mango. Does it taste different?
It's a little bit more sour than the big one.
Okay.
But it's very refreshing. It goes very, very, very well in salad and everything. I use it a lot.
Oh, I love it. I love a sour flavor. So I'm going to need to find that. I'm pretty sure they don't have that in Minnesota. Well, Robin, what are you drinking tonight?
I was working right up until I joined this call. And I'm at my friend's house. So I just ran and raided her fridge and I have a citrus punch. Truly, I'm drinking hard seltzer tonight.
Oh,
this is a first.
Oh, you're like a millennial all of a sudden. It's great.
Cheers.
Cheers. I was inspired by Josie. After she was talking about her Mexican mule, I was like, oh, that sounds amazing. So I made myself a little Mexican mule. All right. Well, Smita, tell us how you got to working with patients with inflammatory bowel disease.
So first of all, thank you for inviting me. I really, really appreciate it because I'm going to start with that and then I'll go back to IBD. So as you see, I'm originally from India and I did my undergrad back home and I'm in touch with those other therapists who have also specialized in pelvic floor therapy. And I was asking them and I said, hey guys, do you see the patients with IBD? What do you guys do with? And they said, really? Can we help them too? Because number of IBD cases in India also increasing. And they were surprised. So thank you so much for giving the opportunity because I really want to spread the awareness that how we can help, right? Okay, so let's come back to how I'm involved in IBD. So I work at Brooke Army Military Hospital and, Lieutenant Colonel Anish Patel and his wife, Lieutenant Colonel Vanisha Wallab, they both. So we are in the team. So at BAMC, we work as a team. And so all our IBD patients, we do multidisciplinary approach. So we will have GI, OB, urogynec, pelvic floor therapist, and behaviors, mental health support. If they need chronic for the pain, they need that pain clinic. Before COVID, we used to have every month, we would do interdisciplinary meeting and we will bring up any case that would be challenging and we discuss. So that's how I got involved in it. And I'm going to go back a little bit. So from India, I came to Michigan. And over there, whenever we would have fibromyalgia case on anybody's schedule, therapist will say, oh, no, because, I don't think I can make them feel 100% better. I'm not going to get that 5 stars that all my therapeutic goals met. And that's what made me think okay, I want to work with those patients. I get really bored if I have to just do those cookie cutter treatments just for back pain, neck pain kind of things. So fibromyalgia, I know that I am never going to fix it, but if I can improve quality of life, then I will feel great. And that's how somehow, got involved in this.
I love that. I love that.
That's amazing. So, I mean, that kind of leads perfectly into the first question I want to ask you is how can pelvic floor physical therapists help people with IBD?
Very good question. So first of all, when it comes to pelvic floor physical therapy, I'm going to ask you both a question. Can I ask you? If I say pelvic floor physical therapy, what comes in your mind first?
I think Kegels. I mean, that's the first thing that pops into my brain.
Yes. And how about you?
So for me, I've had multiple surgeries, pelvic surgeries because of my IBD, and I've talked to other people. So the first thing that actually, besides Kegel, because I think that's just what everybody is pelvic floor dysfunction, but only because I've heard people say that. I don't know exactly what it means. I will tell everyone, the 5 people who are listening, plus both of you, I did go to see a pelvic floor physical therapist for the very first time after having IBD for 20 years. Wow. Was it last week or the week before? And it was like mind blowing. So when you agreed to be on the show, I was like, yay, I can ask her all these questions. So,
well, and I think a lot of people think pregnancy too. I think they associate that with pregnancy, and especially people I would imagine have cesarean sections because it just cuts through everything down there.
Okay. So when somebody just asks me, what is pelvic floor physical therapy? And I always jokingly say it's medical mystery. No, I'm just joking. Just joking. Okay, so pelvic floor therapy, right? When we talk about, it's like we physical therapists do specialization in it. Let's quickly talk about the function of pelvic floor therapy because it's not all about Kegels, and there are some cases we don't even go there. So when we talk about pelvic floor function, first thing we talk about is the continence, whether it's the bladder or bowel. Right? Then it supports those organs. In female, it will be bladder, bowel, uterus, right? It supports. They are the dynamic stabilizers because when we look at in our body, they were somewhere in the middle. So if they are the connector for the upper to lower body. So they have this big function of being a dynamic stabilizer, gives continence. And during the sexual function cycle, it comes when it comes to pushing the baby out. And like any other muscles, they have the pumping action to move that fluid. So that's the action of pelvic floor pelvic floor, right? So now when we go back to IBD patients, I would say anybody who has pelvic floor can have pelvic floor dysfunction. Agree? Whether it's male, female, kids, old, adults, any gender, any age group.
Absolutely.
So with IBD patients, I see lots of fecal urgency, fecal incontinence, nighttime accidents, bladder urgency, frequency, incontinence, bladder and rectal spasms, pelvic pain, dyspareunia, which is like painful intercourse, and just being down there, just fatigue, that poor posture, all those together. So, and then of course, prolapse. I do a lot with the pregnant patient postpartum, but just to cover up.
Right.
So basically everyone needs a pelvic floor physical therapist is what you're saying.
Whoever has the pelvic floor.
If you have a pelvic floor, you need a pelvic floor physical therapist. Just want to establish that as a baseline.
That narrows it down to all of us. Okay.
Yes.
All right. Okay, number one, you say incontinence, all the pain, a lot of these things, but there's already pain and some of the stuff and urgency associated with IBD. So how do you know that you have pelvic floor dysfunction, or should you just assume that you do?
It's a very good question. So for me, I don't get chance to see patients when they are in the acute flare-up. They are medically managed. So when they come to me, they are mostly in remission. So just because somebody is in remission does not mean that they still don't have the symptoms, right? Though it's in the control. And that's where I come into the picture. So if anybody has any type of incontinence, any type of pain, any type of spasms, any of those things that we talked about, whether it's the back pain, hip pain, lower abdominal pain, all those things we can help.
That is remarkable and gives me a lot of hope, frankly. So I would happen to be chatting with somebody today, and she was talking about working with her pelvic floor therapist. And she says she has been able to go off of pain medications that she was having to take a lot because of working with her pelvic floor therapist, because she has so much pain in pelvic floor pain and abdominal pain. How does that work? So you have somebody that comes in, you do your assessment, and they're in a lot of pain. What happens now?
So I want to, before I answer that question, I always tell my patient, or even when other providers ask, that how can we help? Just because somebody has IBD, that does not mean that that body is going to say, okay, this is it. No more. You're not going to have any more problems. They can fall and sleep on ice and can have a tailbone bruise and that's where the pelvic floor is attached. They can blow the disc, they can have hip replacement, they can have allergy, lots of coughing. So all those other issues makes it more complicated. So all those together makes it like more involved. So like when any patient comes for pelvic floor eval, it's such a thorough eval. You want to know what medication you are taking, what surgery, medical history, what type of work do you do, when did it start, what was going on in your life at that time, when did it start getting worse or better, what increases, what decreases. We want to even know what type of birth control you use. If it is hormonal, that can have effect too. We even ask, do you clench or grind your teeth? And I have so many times my patients will say, can you see my dental records? How do you know I use the night guards? It's because the research has shown there is a connection between our orophacial diaphragm and the pelvic floor. So if I have a habit of clenching, grinding teeth, guess what? I tighten up the pelvic floor.
I'm sorry.
Yes.
I'm going to have a minute here where I'm like, I don't understand, but I'm fascinated by this. What?
You will be spending hours on PubMed after this, won't you?
Oh, I'm going
Looking
to,
up this research.
Yes, and actually, my husband, the one who was helping a minute ago, right? He's all evidence-based, research-based. So he's like, whatever you tell, make sure you have something supporting evidence. I have pulled out some articles. So
thank you.
If you want,
Yes.
Yes.
We would
share
love
them.
to share them.
Sure.
Yes, we'd love
Yeah.
to share them.
I
But
will.
just as a note, Robin and I say a whole lot of stuff that's not evidence-based at all. So you're probably okay. However, I get it. We would love to share the articles and I want to see them for sure. I'm excited.
Sure.
Yeah.
I will email you, right?
I'm just sitting here still like mulling this over. I'm sorry. I'm like this is the first time I think I've ever been stymied in an interview where I'm like, I'm still trying to figure this out.
So then we check how the person is sitting, how they are, the way they stand up, their standing posture, how much time they take to move from one place to another. Most of the pelvic floor therapists have a very strong ortho background. So we check from thoracic to the hip. At least we clear, because autonomic nervous system, thoracic area. Then, we want to see the lumbar, sacral, hip muscles. The rotator ones are the secondary pelvic floor muscles. So how things are connected. So that eval is very thorough.
It sounds like it. And it sounds like it sounds like that would take an hour or more.
Sometimes more.
Yeah. But that's so great because then you have all of that information to be able to put the plan together.
Yeah. And we have not even talked about pelvic floor evaluation yet. This is just
wait, we haven't. You're right.
That's the reason I said sometimes more than an hour, depending on the case.
Yes.
Okay. So you do all of that for the first sitting. Then how do you evaluate somebody's pelvic floor? If like Robin just said, she just met with one. So if I'm preparing to come see a pelvic floor therapist, what should I expect?
So we may do internal pelvic floor muscle assessment. It's like if you come and say that my biceps is hurting, what am I going to do? I'm going to look at it. I'm going to touch it, feel it, move it, kind of things, right? But then there are some patients, because of their history, because of so much pain, past history of trauma, whatever it is, if they are not comfortable with it, that doesn't mean that we cannot help them. I don't have to do pap smear. I mean, it will give me better picture, but there are other ways to look at it. We palpate it from the outside attachment, because each and every muscles are attached somewhere in the body. So we do it from outside. Of course, internal muscle assessment will give better picture, but so what? We can still help. So we check their alignment, the pelvic alignment, how everything is leveled or no, if the alignment is off, if their muscles are tight, if there are some tender points, how is the hip flexibility? Because when we talk about pain with the intercourse, it's not just in and out penetration. There are so many repetitive pelvic movement. Do they have adhesions there? Maybe other surgeries like C-section, appendectomy, laparoscopic, any other surgery. So all those things add some coins in that pot. So we try to check all those things. And when we do the internal pelvic floor muscle assessment, there are 3 levels of pelvic floor. So like any other assessment with patient's consent, we would check the sensation, the tone of the muscles. If they are tender, are they able to contract them? Are they able to relax them? Are they able to bulge? What happens with the breathing? Are they able to move? So there are so many things that we check and we grade them. And those are the different things that we do.
How does that change with men though? Because obviously I'll just stop there. How does this change with men? Because I have lots of visions in my head now.
Yes. So I do see the male patients, and right now I'm in women's health clinic. So they are the only ones that come, and I have to tell my screener that, remember, start with Mr. Remember this, because then. So we do lots of with them. Of course, we will have a chaperone, and with their consent, we do check through the rectal area more, and we get because they are the same muscles that we can do. In my clinic, I am blessed. I can use real-time ultrasound. So I check it from lower abdomen, and that really helps me to see it from outside. And that gives them biofeedback. They say, oh, this is what you mean. So those kind of things really help me, whether it's the new patient,
And I think it adds that level of patient education as well to it. It's not just you doing, it's you saying, you teaching about this is what this is, and this is how it affects you. So I'm sure they appreciate that, especially because it is mysterious, like you said. It's
we can't see it, so we don't know what it is down there, right?
Right.
Yeah.
So I many times give them handheld mirror and let them look them down there too.
That's great.
And I teach them. And actually, like how every month we do the breast exam, I tell them to check down there too. You will be the first one to catch any type of changes down there.
Wow.
So
That's a great idea. I have so many lists of things to do now that I'm older though.
The older you get, the more things you have to check.
Crap.
that is.
Yay for aging. I'm going to stop sleeping, and I have a whole list of stuff to do every single month. Maintenance. So once you do your assessment, all of the assessments, what homework do you give people? So how would when you send somebody home, or you're like, okay, do these specific exercises? And because I've done some physical therapy for I fell down the stairs and I hurt my ankle quite badly. I mean, it was remarkable. Don't drink wine and run down the stairs in socks, everyone. So they gave me exercise to do at home. And then when I came back, they assessed me on what I did. So what does homework look like for pelvic floor therapy patients?
Yes. So same thing. Even if I cannot finish the entire eval in the first session, I always start the homework. When I do the evaluation, I always want to know what my patient's goals are. I always do functional outcome scale to understand how is it affecting their quality of life. And then once we do it, I either make them do either bladder log, bowel log, or a symptom log. I want them to be connected to their body, because believe me, our body gives us the cues, but we are just so busy, preoccupied with other. So if I can get that mind-body connection, and we do a lot of things. Once my questionnaire is done, we play around with sitting, standing to get that connection, because that's what helps with pelvic floor. You can't see it. But when they say the same thing, like, how do I know? I always tell them that if I ask you to bend the thumb, you can bend it. If I take it behind, wrap it in the blanket, make you close the eyes, and ask you to bend the thumb, you can still do it, right? And they're like, yes. So that's one thing, to get that mind-body connection, which I want them to continue. So their homework is catch often. Are you clenching your teeth? If you're not chewing food or not saying certain words, you don't need to do that. So relax that. Like first thing in the morning when you wake up, connect to your body. What do you feel? Every often check that. I make a big deal on changing the posture. Even you too can play around, like try to slouch and see how much the pressure changes in our vaginal area. So think about, if I have a progressive lens and I'm typing and driving so much, you see constant. So if we open up that area, that constant pressure on the bladder and bowel is less. So make changes with that. I'm a big on diaphragm. Diaphragm is the driving force when it comes to pelvic floor issues. Diaphragm and pelvic floor, they are connected. They move up and down together. I always teach them the diaphragmatic breathing. And depending on if they are very high in the anxiety, sometimes we get the sense, I will start with the resonance breathing with the exhale longer than inhale to calm down that vagal tone. So do that. If I feel that they are connected, then we start with some stretches. Give them like some opening stretches and things like that. If they have done the Kegels before, I would check it on the real-time ultrasound to see how, So usually in the first session, I don't do internal exam because I want them to feel comfortable with me. And I want them to feel that each and every medical appointment is not stressful. I want them to look forward for this appointment because I don't have to work with those red flags. That is taken care of. So that's what I try to do it.
Do you mind if I take us in a little bit different direction? Because
Sure,
we're halfway in, and I'm really interested. Maybe this is just because I've personally had multiple surgeries in pelvic floor physical therapy after surgery. So anybody who's listened to more than one episode knows that I had my colon removed 20 years ago. I've had 2 babies naturally. And then I had a J pouch a year and a half ago. I can't believe it's already been a year and a half ago. And then I had the takedown surgery. So I've had multiple surgeries and had children. And not one time over the course of all of that was it ever like, oh, you should see a pelvic floor physical therapist to rehabilitate after surgery. It wasn't until my new GI that I have just since changing states, I mentioned incontinence after the last surgery. And she said, well, let's just get you set up with a pelvic floor. I didn't ask about it. She immediately just said, let's just get you set up when I talked about incontinence. So does it make sense to have pelvic floor physical therapy after surgery, major surgery, colon remove, J pouch, ostomy, all of those kinds of surgeries with lots of IBD patients have? And let's just start with that. Does it make sense to have this kind of rehabilitative therapy after that kind of surgery?
Yeah. So like when somebody has the acute flare-up or somebody has this, we may not do the direct manual therapy in that area, but remember that myofascial sheath that's from top to bottom, everything is connected. I can do the triplanar movement, moving the arms in the different direction. If we start with, whenever we have pain, what is human body's tendency to go into fetal position? So we are just feeding the fire. We are just getting more and more tight. Now, some bodies scar easily. I have 2 C-sections and appendectomy. So that area mine also has. So I understand that. So we can always do that indirect mobilization to improve, because my thing is, if we do not address it, if my clothes, and I'm going to just show you here, but say if down here I'm tight, now you guys all of a sudden will say, what's wrong with her shirt up here? There is nothing wrong here. So same thing, if you're anybody who is tight down there, if we don't take care of it, guess what? They will have back pain, SI joint issues, all those like that. So those who have active issues going there, I can still do the indirect mobilization and help them to open up and do all those stretches. So yes, and that's where I always, whenever I meet the providers, I say, please ask your patients, right? Just because they are in remission does not mean that all the symptoms are gone, right? All those issues. And that's where, yes, it can be very helpful in the form of stretches. I do the scar release, gentle, whatever. If not, we can even just do the K-taping, even if we don't have to dig in. So every time you move, it kind of gives that movement and loosens up. And that pain fear cycle, like that trauma, oh my gosh, I have 5 surgeries there. That mental trauma is huge. You want somebody else to say, it's okay. It's completely okay. This is not going to harm you. And we do it. Of course, we wait for 6 weeks, 8 weeks until your surgeon says, okay. I always communicate with the surgeon, try to understand the surgery so that we are safe, and then we go. And that's where I always like multidisciplinary approach, where I can be able to reach to all your other providers.
I'm curious if there's something you can do pre-surgery to prepare, or is it like once the surgery happens, the damage is done and then you have to fix it? Like, is there anything to do pre-surgery?
No. I think like with the knee replacement, hip replacement, all those things, they have pre-op visits. I wish we can have this for the patients too. It's very easy to teach certain things before surgery, then after surgery, at least. And then we know the baseline that if I see somebody who comes after surgery and I'm like, oh my God, this person is so tight. But if I would have seen that person before, I'm like, she had the hip tightness. So we know that which was pre-existing and which is something new. So that rehab changes. So at BAMC, before COVID, we used to do twice a month, and I've started again. I do this women's health seminar, which is 2 hours torture. No, but they enjoy it. So that's where I give so much information. Anybody, the DoD beneficiary can come. So all those things are explained that can work. I am for pre-op appointment, at least one to get your baseline, to teach if needed Kegels, if your pelvic floor is tight, what is going on, so that we know which were already there, what to expect.
This episode is sponsored by Romanwell. Have you ever felt overwhelmed and unsure about what questions you should ask your doctor, or if you should get a referral to a dietitian? If so, you are not alone. The dietitians over at Romanwell help patients every day navigate these questions and many more. They've just released an amazing free resource for patients called the IBD Patient Starter Kit that is jam-packed with tips and tools to empower you to become your own best advocate. Check out the show notes or head on over to romanwell.com to download a copy of the IBD Patient Starter Kit today.
So Robin asked a personal question, so I'm going to ask one too, even though I don't have IBD, but I feel like it's connected. So I do, because I'm a bougie white woman, I do Pilates. And in Pilates a lot, they're talking about, can you feel this in your pelvic floor? When we're doing student movements, I cannot. And so how do I actually find my pelvic floor? Because I feel like I don't know where it is. And
you're not the only one.
Okay, good. Thank you for normalizing that for me.
I think the worst thing one can do if they don't know is like, how many of my patients will say, oh, I do the Kegels exercise. And I would ask them, how do you do it? By stopping the urine flow. Please, whoever is listening to this podcast, please don't do Kegels exercise by stopping urine flow, by cutting your urine stream, because that creates the dysfunction. When the butt touches the toilet seat, it's time to relax and pee. Pelvic floor has to relax to pee. So when it comes to the Kegels exercise, it could be part of it because, we are not connected. So maybe one time just to understand, to get that aha moment, that is, or like putting the hand outside the vaginal area and thinking about as if you're taking it away. Or I will tell my patients, imagine there is an elevator down there. So closing the elevator door is engaging the first level. And think about that elevator is going up, up, up. So that's engaging. Sometimes when you breathe out, that helps because remember they are connected. The other thing we can do is like using overflow where you push the tip of your tongue against the roof of your mouth. That can help. Real-time ultrasound. Sometimes I use the biofeedback. So those are the different things that we can do and one can try.
Thank you. I shall practice this. I like the elevator. I like the visual of the elevator.
And
I feel like
if you have a big that exercise ball, the Swiss ball, if you sit on it, wherever that vaginal area is touching, think about you want to lift it up. So that's what
all right.
That's where you can try.
Very good place to start.
Yeah.
Very good place to start.
The pelvic floor physical therapist that I saw also used the elevator. Like that was the exercises that she recommended, was using the elevator door analogy.
Can I show you something? So this is like a dilator. I got all some of my tools too.
Oh, yay. We love visuals. Okay. Except for we might have to do screen grabs for this.
Because of the COVID and all, I have to have everything covered, but can you see it? Mm-hmm. It's like a dilator. So many times I use this not only for the pain, but when you have this, when you put this in, it gives you, this is what I have to squeeze around it. Right. It gives that proprioceptive feedback.
Yep.
So that is one. I use this a lot for the pain patients and they come in different sizes. So this is small, from extra small to all the way to extra large. So then bring us the message that each and every penetration is not painful. Many of my IBD patients have some inflammatory joint issues too. This is very hard to put it down there. So then there are some dilator that comes with the handle. Can you guys see it? So that makes it a lot easier to use it down there.
Well, and that one it's quite thin as well. So I think that
Makes it easy.
Yeah,
And
some folks
then
might tolerate that better.
Like how you get the trigger, like when you had that ankle thing, you have they do the manual therapy trigger point release. There are different wand that can go in and you can touch to help to release that area.
That looks like a snake.
Yes, because of the, okay, so this is the biofeedback that those who have pelvic floor dysfunction, pelvic floor dyssynergia, biofeedback, I don't know, all those words. So this is the handheld machine that we can talk about when we go to talk about that, because we gave lots of importance to Kegels, but there is other side that we need to talk to.
Well, let's keep talking about it then, because now you've got me very curious.
Okay, so Kegels, yes, we do when the muscles are weak. I understand. But remember, pelvic floor function not only has to contract, but it has to relax too. If it doesn't relax, then one will have pain, will go to pee and they're like, oh, in 10 minutes, I have to go again. Or they sit down to poop and all of a sudden everything just spasms there and you just can't poop. Pain with the intercourse. So there's a long list of things, right? So those are the ones we are not going to start with Kegels, those who have pain. If my elevator, remember that elevator, if it's stuck on the 3rd level, what am I going to do? It has to come down before we teach how to go up, right? So they are the ones we will start with the relaxation first, teach them to relax, and then, because when we are constantly holding, and which is very common with pain, with stress, who are trauma survival, and anybody, like we hold our stress at different place. If my pelvic floor is tight, who is holding it tight? My muscles. That overuse creates the fatigue, creates the weakness. So first we have to teach them to relax, and then we teach them to do it.
Do you see that more commonly in people with IBD? Because I mean, when you were saying keeping it tight, I'm thinking incontinence, people who have urgency must hold really tight on a regular basis.
No, it's as per demand. Pelvic, and that's the reason. So like, now this sounds like I'm like a dinosaur, but like 12 years ago, 15 years ago, when I started training, we used to do everything, like put those electrodes, 10 counts, 10 hold in supine position. But this is, we are making a skyscraper here, and then we are expecting that it will stand up when we make it. So now we teach Kegels to kick in as per demand. So we use the word pelvic floor contraction. And the other thing, important thing is to push a refrigerator, the amount of strength I need, and to push just a pile of 3 pillows, it's different. So we have to teach that pelvic floor to kick in as per demand, as needed, not always like this. So those are the things that we teach them in different positions during different functional activities, things like that. So yes, with the IBD patient, because they are afraid that fear causes so much that tightness. So I see a lot. So we work a lot on letting it go first and then do it.
How does the biofeedback work to help with that?
Thank you. So this is a handheld one which can be connected to the laptop also, so they can see on the screen. I prefer handheld because what I do is there are 3 electrodes, button electrodes, disposable one that goes around the anal area or perineal area, and the other one goes on the stomach. And then once we turn it on, hopefully you should be able to hear. So that's what, and it shows the graph also, things like that. So that gives them the feedback. I will tell them, okay, I wanted to quiet it down, take it under 2. And then we work on different ways. I teach them how to do it. We have those bedside commode seat. I take my patients over there, make them sit on that and teach them how to relax that puborectalis.
That's so cool.
So for that dysfunction, because that pelvic floor dysfunction, and there is one article that I will send. If I can quickly read that line, I really wanted to, which says that non-relaxing pelvic floor dysfunction is an underestimated complication in ileopouch anal anastomosis, and it's almost 75% of patients would notice that. Wow. I wanted to read it correctly so that I don't.
That's perfect.
I will forward you those articles to you.
Please do. Yeah. And
Yes.
that's remarkable number of people.
Yeah.
But I think it's great that you put it in real time. Like, you're giving people the feedback from the biofeedback machine, but having them sit on the toilet, it's sort of like you said, you're connecting it to this is when I do this. And I love that.
And
This
then
is
we can
great.
use the squatty potty there, or we can teach them how to bend over or make that grrr sound, different things that we do it, or make them squat. All those things we can do it there. So then they get that connection.
So fascinating. This is so fascinating to learn about.
It really is.
What about pain? So the person I was talking to today specifically mentioned pain, and she said there's a massage that they use as well. So what do you use for folks with pain?
So pain, first of all, everybody hates pain. So first I want to tell them that pain is a protective mechanism. If I want to work with you, and if I say, but I just hate you, it's never going to work. So I always want them to first accept the pain, understand pain, what is chronic pain, what are the different factors, the layers, there is emotional pain, those kind of things. So the massage, when we talk about if there is any scarring, that massage comes like how we have the tender points, the pelvic floor muscles, the levator muscles, the obturator internus. There are different levels, right? All those muscles can have tender points. So those areas have such good blood supply that even very little thing we can do the myofascial release. Things like that. We use the breath work. We use strain, counter strain, all those different things too. So yes, it's like somebody who has 2nd degree, 3rd degree, 4th degree perineal tear. If that area is tight, we teach them how to massage it. So things like that could be the one they must be talking about. Many times the nerves coming from sacral area, maybe that area first we need to calm down. The thoracic area, the tailbone, that coccyx bone, that's where all the pelvic floor, so many attach there. If that area is tight and tender, we release that area. The pudendal nerve that comes to that area, so that pathway, it's like, release that. So depending on where they have the tightness, guarding, trigger points, tender points, those are the places we work on.
Well, that immediately made me think of Dr. Kane, and also one of our other guests. We got talking about fistulizing disease and in particular retrovaginal fistulas. So I would imagine that when you have that, once it's healed, that you probably would benefit from having somebody.
So yes, a lot of things we will do first, the external, because how well the things have healed, and I would listen to surgeon what they say. But surgery is one thing, but then around that area also everything starts guarding. If I had that major surgery, it's there in my mind too, and I'm going to be all guarded. That's not needed. So all those starts, there are so many indirect. I am a yoga certified teacher, so I use lots of those restorative yoga poses to open up that area, use the breath work, because breath work works great when it comes to the pelvic floor issues. So doing that way indirect, but I will be in touch with the surgeon, make sure what are the things absolutely not to do and what am I okay to do it, things like that, and we go from there.
Well, and I definitely want you to talk more about yoga, because that was one thing you noted on your questionnaire with us, is that you wanted to talk about that connection and the benefits. So please tell us more about that.
So when we talk about IBD and when I see them in remission, I treat like a chronic inflammatory disease. As per yoga, anything that is chronic inflammatory disease, there are 3 things we need to take care of. And it can be in any order: sleep, stress, and diet or food. Isn't that true? If out of those 3, one is off, or all 3 can be off nowadays, that affects so much. So I always, because many times, I don't know, like even IBD patients will say, why with certain diets? Sometimes I have so many issues and sometimes my body is okay. Many times it's because the other 2 things are off. So those 3 needs to work in harmony. And that's where I use that for restorative poses. And then I feel like when they do yoga, it's something they feel that they can do on their own. Lots of breath work, meditation, mind-body connection, like how we do that biofeedback. So many of the same thing that yoga uses the same principle. So many things are overlapping. So some of those things I use it here, and that really helps me. And then especially if it's a group setting, can you imagine if we have a group setting of IBD patients doing yoga? It makes you feel like you're not alone.
Yes.
And you support each other. This is what we are doing, right? That's the reason we're doing. And that's what I see, that when we do in a group session, the outcome is good, better. When it's in the maintenance phase, that's where. So I use yoga as needed for my patients.
Are there specific poses that you would recommend that people get to know real well?
So depending on where they are, anything that's the opening poses, that's what I use a lot. Whether it's again, I do look at their medical history. We're not talking about somebody having total hip replacement or having a spinal fusion. We're not talking about that.
Okay.
So we use a lot about hip openers, psoas muscles, because that's where all those nerves, the way they pass through, autonomic nervous system, that's the thoracic area. If I'm going to be like this, it is going to get affected. So opening of this area, opening down there, yoga believes in so much of posture. So sitting and standing posture, getting those core muscles kick in, because now they are on vacation. They are inhibited. They wake them up. Yoga pays so mula bandha, those who have done yoga, because they realize the importance of the pelvic floor. It's the base of this abdominal cavity. It's the foundation. Not only that, they say we enter this world through the pelvis, right? Coming out. Mm-hmm. That should be the first thing that we need to start working there and then build up. So I use a lot of hip opening pose. Spine, that's my another thing that I work on. And of course, it uses mula bandha, all core muscles, and the posture. So depending on where they are, either we use lots of props, blankets and cushions and things like that. When they are ready, progress to sitting, standing, things like that.
Very cool. I started doing yoga later in life, like just in the last kind of 2 years. And
me too.
Yeah. And
I love it.
Yeah, me too. But I think it's nice. Like you said, it gives you a little bit of that control back. You're like, I can do this thing for me. And, it's independent of my disease. So very cool.
I would like to ask, so we've talked a lot about people who experience the tightness of the muscles, and we've mentioned the elevator, learning how to release, and Kegels, but what do you do for someone besides Kegels who have low muscle tone, low muscle control? Because we're talking about the tightness. What about the opposite of that? So, I'm assuming just like there are the levels of tightness, there are the levels of muscle tone, where some people have some muscle tone, some people have no muscle tone. And, do you start with Kegels? I'm asking a ton of questions. No, I'm asking too many questions again. This is why Alicia has to ask the questions, because I'm like, what about this? And what about that? So you know where I'm going. I'm assuming you know where I'm going.
Yes, it's a very good question. Yes. Even if those who are tight, eventually we have to strengthen them. That remember, because they are dynamic stabilizers. So we have to kick them in. So we grade those muscles from 0 to 5. 0 means nothing. No matter, even if I give the cue inside, they're just in shock. Then we use, I don't have it, but I'm just going to pretend it. There are internal electrodes that we put it in, and we give just a very little electrical stimulation. Wake up, guys. You are there. Wake up. Unless they have some type of major pudendal nerve injury or something, or sometimes that levator muscle can tear. We are not going that all the way. But once they wake up, then we start doing it in gravity assisted. So put a pillow, like when you are in knee bend position, supine hook line, put a pillow under the butt. So now when they do the Kegels, that gravity is your friend. That can help. And then, there are some overflow activities that if you push the tip of your tongue, that kind of activates. When you breathe out, those kind of things. So once they can do that, then we take that pillow out. We do it in sitting. We put something under that butt. So when hips are higher, that lumbar neutral spine helps them to work better, that elevator. We do it in standing in ski jump positions, when they are bending over, squatting. So Now we make them like, guys, you need to kick in each position. Not only that, I actually, San Antonio allergies, if you guys know, that coughing, sneezing, oh my God, last 2-3 weeks, I teach them how to engage those muscles and cough up and out. So things like that. So it's not only just strengthening like this. Of course, we need that strength too, but kick in as per demand. And then how can they work with other muscles? Because transverse rectus, those core muscles, and pelvic floor, they are synergists. So they have to learn to work together. So then we are different. So like how I use this, there is something called, there are different vaginal weights also. Those who have to do certain type of, they are in certain type of profession where they have to do heavy lifting or lots of climbing or things like that, maybe they are the ones we may use that. I use a lot of real-time ultrasound where I have that on their abdomen and I say, now go ahead and lift your leg, but keep them engaged. So they see it. Oh, I'm losing. Then they recorrect. It's beautiful when we work on the ultrasound. So then I make them stand on like Dynadisc, that wobbly thing, so that those muscles kick in. So we challenge them in different, sit on a Swiss ball, see if you can do it in different positions, engage those muscles and challenge them. And so like how I said that pelvic floor has to relax and pelvic floor has to contract, because
Yes.
if they're too loose, we can have leakage and prolapse and all those kind of things, pain and all. Here, if they are too tight, then it's the issue. Then there is another thing where they are just a little bit confused. So when they have to relax, they start relaxing and all of a sudden they tighten up. Very common during those who have anorectal manometry, arm test, they will say pelvic floor dyssynergia, where all of a sudden that muscle tightens up. So that's where we have to teach them when to relax, how to relax, and not to all of a sudden tighten up. That's where my biofeedback also helps me a lot.
Now I want to go back and look at the results from my telemetry test before my J pouch and see if it said that, because I call that the alien invasion test, by the way. that anal telemetry, the balloon thing. Yes, there are things that they put there to test you that never should be.
Wait,
there.
I'm sorry.
So,
pause.
Yeah.
What exactly do I feel like we need to talk about this? What do they do?
Okay, so, and then please correct me or add on. So for me, so you're laying on the bed side, on the medical bed sideways, and I'm going to just talk about the balloon that they insert into your rectum through your anus, and they inflate it and they deflate it, and you have to squeeze and you have to try to expel it, and you have to try to suck it back up. I mean, there's many things, and there's other things that I had to he's going to hate me for saying this, but my poor husband stayed in the room when they did that test because he wanted to be there for moral support. And afterwards he was like, that just seemed like the most painful and uncomfortable thing that I could have ever seen you go through. And I'm like, you never have to stay in a room with me again, babe. Don't worry about it. Again, I call it the anal probe test. I mean, the alien anal probe test, because it's like what I would imagine people who have been abducted by aliens go through.
So when we do our pelvic floor training, and there are different levels, right? They teach us how to do that balloon retraining. Now that arm test done by GI, because then they are going to give you the diagnosis. If they say they had hard time, they failed that rectal balloon explosion test, then we retrain. So there is a kit, we use it individual, we put it in and we inject the water in it. That's what, inflates it. So things like that, but that retraining help. It's not comfortable, but
no, it is not
help.
comfortable.
And I have patients whose pelvic floor muscles are in spasm, especially if they have fallen on the tailbone and all that area is spasm. Then many times we do it, of course, with the patient's consent, but release from the rectal inside, and then they can sit better. Their pooping is better. That constant feeling of I'm sitting on a golf ball is gone.
So they had to do that test for me, Alicia, to check my sphincter muscles to make sure that I still had enough muscle tone to be able to hold. because my ilium, they created the J pouch with my ilium, and it is connected to a very small rectal cuff, which is right to my anus. So they had to make sure that I still had enough sphincter muscles to be able to hold it. And otherwise I would be completely fecal incontinent, right? If you can't hold it. So that's why they do the test for people who are about to have J pouch surgery, to make sure that you have the muscle control to be able to still hold the stool.
Right.
Yeah.
So that's going to be common for anybody looking at a J pouch surgery. Okay.
So then when we do the retraining, that we make them more focused around that anal area, hold that contraction a little bit longer in that area. We train them with the fecal urgency, how to hold your urgency, because like I have one of the male patient right now, and we had to measure at his workplace how far is the toilet, and he needed at least 3 minutes. So our goal to train him to able to hold his urge for 3 to 4 minutes so he can lower down his pants.
That toilet is far away.
Yeah, because he's a high school teacher, and by the time you go, you have to stop the class and you go. So we needed 3 to 4 minutes.
That makes sense.
That's where controlling, but that's where we check that tone, teach them. And the other thing is the stool consistency on the Bristol stool scale. If you guys are aware of that, if somebody has 6 or 7, it's very hard, very difficult. We want to have them at more around 3, 4, kind of, if you're traveling somewhere, 2, 3, 3 is the number, like more like banana type of, not that liquidy, because it can just seep out. So that's the different things that we make the changes and work on that urge control.
This is so fascinating. And I would talk about this longer, but I think we're like, this is going to be like a 3-hour podcast at this rate. Cause I'm like, keep talking. This is so fascinating. I mean, like, I'm learning so much. I feel like I need a pelvic floor therapist. No. I'm like scared. I'm confused. I'm excited. No. It's so many emotions are happening right now.
I'm just trying to keep this from turning into a personal consult. I want to ask questions about my personal situation, which I'm not going to do.
Can I give just one message to all the listeners? One thing is the help is available. It's okay to ask. It's okay to discuss with your provider that I have this issues. I mean, it's pelvic floor is down there. Nobody wants to talk about it. It's like a taboo thing, but it's okay. It's just the human body. It's the function. We providers should ask, but if it's okay to ask, there is help. And when you look for a therapist, please call them ahead and say that, do you have experience in this? Because I've done my board certification, but there are levels of classes. Not during the first class, they teach us all. Male pelvic floor therapy by itself, it's a class. Fecal incontinence, constipation, all that is by itself, it's a thing. So it's a good idea to ask beforehand. Patients call me and I actually like it. That means they really want to get better. They're going to be involved in their care. So please, please, please do ask. And you're not the alone. You will be surprised. There's so many people. Those who ever have pelvic floor can have pelvic floor issues, period.
So that really does kind of answer our last question, is what's a piece of advice you would give for patients? But I'm curious about, do you have advice for providers?
So yes, the providers, like I get chance to work with my residents. So new residents, when they come, I get chance to, with OBGYN, Euro, whatever, right? I have a little sheet with the 10 questions, things like that. And I tell them, give it to your patients. If they say yes for more than 3 or 4, they will benefit from pelvic floor. So your initial, just ask patient, do you have any type of bladder bowel issue? Do you get pain with intercourse? How many patients are going to talk about that, right? So we as a provider, we have to ask. I always tell them, because it's not only that they're embarrassed, they are not even aware of that this is help is available, right? I have so many, nobody told me I had diastasis recti. I kept wondering, I lost all the weight after my delivery and all. Why my back hurt so much? Because I had such a bad diastasis recti. Nobody talked about, nobody checked. So now that we have awareness, let's spread it, that help is available. It's okay to ask and say that I have this.
Right. Well, and I think that's a super important thing to say, because what you're talking about are things that maybe are stigmatized or scary to talk about. And you don't know what you don't know. This is the thing that's magical about pelvic floor therapy is I'm thinking like, I didn't know any of this was available, but now I'm like, everybody needs this, number one, and definitely everybody with IBD needs this. But if people are not willing or open to talk to their providers to bring this up, they're not going to find that help. And who knows what else is out there that you could get help for that you're just dealing with.
Yes. So there's something called like either phobia or that medical trauma kind of things, like where every time you go, you come back out with pain. Like, like my kids will call, they have to go for blood draw often. They call, we are going to a vampire, because they hate that, right? Things like that. I want to tell them that pelvic floor therapy does not have to be painful. If you don't want internal muscle assessment or internal work, we will not do it. We can still help you. There are different ways. We give you control. There is always that consent before we touch your body. We ask. There's nothing that's red flag that we are working, that we have to get it done. So please, it's okay to say, and those who have that type of anxiety, phobia, white coat, whatever word you want to use, medical trauma, I always involve some type of counseling or behavioral help, because it helps. It just helps them to feel better and improve that quality of life.
Thank you so much for sharing that. I personally would say that after seeing a pelvic floor physical therapy myself, and especially after spending an hour with you, I have hope that things that I normalized, that I thought I would just have to live with forever because of the surgeries, because of having babies vaginally, I just thought that is my reality from now on, and I just have to live with it. And I'm actually getting choked up a little bit here. I have hope that it can be corrected and I can fix it. And I'm going to stop talking because I'm about to start crying.
Don't cry.
No, I hear you. I get those hugs and the cards that I get. I break down in tears.
Even for people with fecal incontinence, especially after having the IPAA, the J-pouch surgery, like I know that we've had people on this show that I have spoken to outside of that have said, when I've asked them questions about what to expect myself with a J-pouch, they're like, oh, well, you'll have some leakage and you might have an accident. And listening to you, yeah, that may be true, but it can be better. It doesn't have to be a normal everyday occurrence. And again, I go back to that. I mean, it just gives me hope that these things can be, if not corrected, at least improved.
Yes. And I understand that we have issues here at the opening part, but what about the pressure from the top? Can we change that? Can that make the diet that we eat? There are so many things that we can change it to improve it, right?
And I would imagine, especially, Robin talked about having like her rectal cuff being different, smaller, different than somebody who has not had a J-pouch or their colon removed. I'm sure there's things that you can do to help train that rectal cuff to be a little better.
Yeah, now they have started coming out with the rectal dilators. Their shape is different. They work differently. So again, I would talk to the surgeon. What are the things depending on each, not only you, I'm just saying, just in general, anybody who has surgery, I ask, and then add those things and they see the changes.
Gosh, this is just bringing up more and more questions. We really, we need to bring you back, because I'm like, now I have questions about this other thing too. This was absolutely enlightening. And yes. I'm so glad that Robin got teary-eyed and hopeful, because that's what we do this for. Frankly, we want people to look at this and go, I have an answer.
You know what? I really want to thank you not only for inviting me, but what you guys are doing.
Thank you so much. We really appreciate it.